So I guess my first thing is pretty much double check with PowerPoint. The pharmacokinetics of interviews. Like I understand what it does, but how does it exactly work? Interviews.
Interviews. Yep.
Okay. That's exactly what I was going to ask. Because I get that it makes you sick and all that, because you drink alcohol.
Okay. So. Okay. You can only get the pharmacokinetics of interviews in context pharmacokinetics of alcohol. So this is the normal metabolic pathway for alcohol. Ethanol is metabolized with dehydrogenase into acetaldehyde. Acetaldehyde with aldehyde dehydrogenase becomes acetic acid, etc. Okay? So what happens when you add disulfiram or antabuse to the equation is this second step is broken. So you produce the acetaldehyde, but the acetaldehyde, the antabuse blocks the aldehyde dehydrogenase. So you're left with this at very high levels in your body, which in and of itself won't do much. But if you combine alcohol with acetaldehyde, you get what is known as acetaldehyde syndrome, or in simple terms, puke your guts out. So that's what antabuse is basically. It's making it aversive to consume alcohol. And if you're trying to abstain, pretty simple consequence. That's all right.
As you're going through steps 1, 2, 3, some of that's stomach, some of that's intestines, right? And some of that's further down. Do we need to be concerned about that? Okay.
No. Alcohol dehydrogenase is operating everywhere. So yes, it is operating in the stomach in that first pass metabolism we talked about, but it's also operating elsewhere.
It is.
Yeah, the enzyme in the stomach is alcohol dehydrogenase.
Yeah, but that enzyme is other places?
It's the primary enzyme that breaks down ethanol.
It is. Wow, I didn't remember reading that. Of which women have less.
In their stomachs.
So interviews is only acting in the stomach.
It's acting in the whole body. Whole body. Yeah. Alcohol dehydrogenase is pretty much broadly distributed throughout the body. It is the enzyme that's going to break ethanol down.
But the combination of the two, it acts as like a. Well, how does it make you puke? It's acting
This is actually toxic.
Okay.
So what happens is this acetaldehyde is in and of itself making you sick. Acetaldehyde with more alcohol, elevating your acetaldehyde levels even more, is going to make you sick. So it's the fact that your acetaldehyde levels get really high that's problematic. Now, it's a great question. So if you want to know exactly where that's operating, is it the emesis center in the brain? That's a good question. I don't want to say yes because I'm not sure. So we have a vomiting center in our brain, and it monitors a bunch of different variables and decides when it's time for us to throw up. And I can't say for sure that the acetaldehyde is building up here. I do know that excessive serotonin levels will cause the emesis center to activate, but it makes you sick.
But only in the presence of alcohol, right?
Yeah, so when you take your next drink, you get sick. Otherwise, you're fine.
Okay.
You're creating more of that.
Yeah, it's because you're getting such elevated levels of acetaldehyde. That's what makes you sick.
What if your next drink 6 months later?
Thank you. No, only with it. So that's when you're taking antabuse on a maintenance program. You don't take it once. You can take it every day. But it does nothing in and of itself. It's not psychoactive in any way.
Are there any other drugs like that that do what it does, but for different things, like alcohol instead of alcohol? Like cheesecake, you know, what if cheesecake makes you gain a lot of weight? Wouldn't that be a great way to, or cigarettes, you know, you start smoking, you start throwing up because you're taking some compound.
They tried, I think there was, we'll get, when we get to nicotine, I'll try and find it. There was something they tried like antabuse for nicotine. Don't think it was terribly successful. They tried, it's not exactly the same thing. They tried an opiate antagonist, a competitive antagonist for opiate addiction, heroin addiction, naloxone. But the problem with naloxone, it displaces the opiates instantaneously. But you also go into withdrawal. So basically it takes you from high to withdrawal in moments. And I mean, you're in full-on heroin withdrawal in 2 minutes, which turned out not to be very productive. People never came back for a second treatment.
Could that be fake?
It certainly could be. I mean, you know, depending on the dose and the severity of the resulting symptoms. I don't know about fatal, but how about life-threatening? Now, naloxone's pretty amazing if you just don't eat.
Oh, no, you can just stick it in there.
Yeah, you come back to life.
Does the EMTs have that on their truck?
I don't know if EMTs do, ERs do. It's a standard, I think it's standard first protocol for opiate overdose. You hit them with naloxone.
So in the first, in the beginning, when you're talking about ethanol, you said you were unsure of it, and then later you said you know it binds.
Yeah, and that's why I did that ethanol 2 addition. There's no question. It's GABA based. We know there's an ethanol receptor on the binding site on the GABA receptor because the molecular shape of the alcohol, whichever kind it is, however many carbons, is physically specific.
So how does that change when we look at earlier slides when we first talk about it, or are they all still?
Just where it says unclear, unsure, change it to no, we're not.
Okay.
Yeah.
I was assuming that was only for the depressant effect, not for.
Other effects as in,
I thought it just went everywhere, gone to another specific place.
yeah, I don't know that we really talked about any of the other effects. I mean, alcohol does have some other effects. The psychoactive component is the depressant. That's the only thing I really talked about. Now, that same action, binding the GABA receptor, reducing calcium. So it had 2 actions, if you remember. So pharmacodynamically, 2 things happened. One, ethanol binds in the glutamate receptors, or actually, here's the big thing. It blocks calcium from coming in on the presynaptic side. So if calcium can't come in on the presynaptic side, you're not releasing neurotransmitter, actually. Yeah. So the calcium is out at the terminal versus at the dendrites. And so the calcium is kind of that last step. So the action potential arrives at the terminal, and it doesn't actually cause the release of neurotransmitter directly. What it does is that when the membranes depolarize, calcium comes in, calcium prompts the release.
And that's the same with the dopamine function, right?
Yep. Okay, then, so that would obviously be inhibitory or depressant. Then the other, it potentiates GABA receptors through its own binding site on the GABA receptor. And it, let's see, yeah, it doesn't say here, which is good. It's not dependent on GABA, where ethanol can do this on its own. It opens that receptor all by itself.
It binds to the GABA site itself?
Yeah. So when ethanol binds on, it opens the ion 4, lets chloride in all by its lonesome. So that was a kind of cool little thing we did at the end that you guys got me to think about. If I pharmacokinetically reduced your GABA levels, what would that do to ethanol's depressant effects?
That would do nothing.
Correct, because ethanol is independent of GABA. What would it do to barbiturate's effects?
nothing to
Perfect.
benzos.
Exactly. What would it do to Buspirone effect? Because it ain't even gathers. Yeah, perfect. And I thought that was a really cool, everybody getting that? I thought that was a really cool thing we did.
You just said it's not even a GABA.
Buspirone. Buspirone has no GABA involvement at all.
Going onto the other stuff.
Yeah, that got lost in the serotonin and the dopamine specifics.
So how much detail should we go into with ethanol, like the serotonin effect, the opioid, the cannabinoid?
Good question. Give me a second. Let me see what I think is really. I don't need to do that. Focus on GABA. Okay. This is sort of the GABA. And as I said in class, and I realized in retrospect, I really should have called this unit the GABAergic drugs, because it's what we're focused on.
I was going to ask about the serotonin effects, because I was looking at it and it just didn't make that much.
Focus on the GABA.
Was it barbiturates or benzodiazepines that the book said if we could go back in time, they would probably name that class the GABA something, agonist or antagonist? But they class
Benzos.
Benzos? Okay.
Because that's exactly what benzos do.
Yeah.
They allow GABA to act more efficiently.
Allosterically modulate. It sounds so intelligent.
Yeah, but it doesn't sound like what it does, even though I'm sure it breaks apart that way.
It just changes from nearby.
Allo. I mean, that doesn't mean remote to me.
But just remember what it means. Changes from nearby.
I remember I found it interesting, but the rats on the treadmill, when I looked at it the second time, didn't
Yeah.
click.
Okay. That's a good one. And that's really cool behavioral pharmacology. Okay. So here we go.
Right here with every question I had, you asked it right before I did.
Okay, so this is time off the belt, which we could call how drunk are you? All right? And this is the brain concentration of ethanol from low to high. And then there are three plots. One collected 10 minutes after the drug is administered, 30 minutes after the drug is administered, and 60 minutes after the drug is administered. So let's take this point right here. It's a blood concentration of almost 2, or a brain plasma concentration of almost 2. And the rat the rat was really drunk, right? Spent 90% of his time off the treadmill. Now, let's go over here. Let's take, I don't know, we'll take this one. Blood concentration is way up over 2.5, and yet he had no trouble staying on the treadmill. Okay, now, we can assume a couple of things. Pharmacokinetically, would there be any differences between these three groups of animals? You're getting alcohol, 10 minutes later I'm testing you, or you're getting alcohol 60 minutes later I'm testing you. Would you have developed miraculously some kind of metabolic?
So this is just kind of getting used to the action.
Yeah, so it's not metabolic, it's not pharmacodynamic, it is behavioral. That's what the study's about.
That's what you should take away from this slide.
Yep.
Each dot is a rat,
Yeah,
and none of the rats, this is a one-day thing. For
it's
30 days.
it's an acute, yeah, this is an acute dosing protocol. So basically, they intubated these rats and squirted a bunch of alcohol in their stomachs. Which is a real wild dosing plan. You have this long needle called a gavage needle, and it has a little ball on the end. And so you grab this rat, and you hold him up, and you put that ball right in the back of his throat, and if you wiggle it, he'll swallow the ball, and it just takes the needle down with it. You inject it, you just pull it back out.
Is the needle kind of bendy? Or is it straight?
No, it's curved to fit a rat's esophagus. But it's wild, you don't put it in. That's the, when they're teaching you to do this, you don't actually force the needle down. You just hold it, and then it just starts going. And you just follow it. And if you force it down, that's very unpleasant for you and the rat. Because you can push it right through the wall of the esophagus, and that's kind of time to deal with that. So anyway, that's how this would have been done, probably intragastric. They put the ethanol in the stomach. Did that answer the question? So it's behavioral tolerance.
When you're talking about aspirine,
Buspirone.
no, the stuff that makes you throw up.
And abuse.
And abuse.
And abuse, okay.
You were talking about enzymes everywhere in the body and the enzyme thing. Okay, does that go for everything we've talked about? Generally speaking, that
So
enzymes are
all of
everywhere?
these drugs are primarily metabolized where? Or, let me rephrase that.
Yeah.
Primarily metabolized by what?
Enzymes?
What kind?
Specialties.
CYP enzymes,
Okay.
which are liver enzymes.
Okay, but are you going forward, or does that happen in the liver necessarily?
Happens in the circulation.
Because, okay, see, I'm picturing it happening in the liver, but the liver's just making them, and it's sending them out everywhere.
Yeah. Now, does it happen in the liver? Yes, it does.
Well, of
But it
course.
also
This
happens
is part of
elsewhere in
it.
the circulatory system. So if you've released a bunch of CYP 450Y,
2d6.
yeah, whatever, it's going to metabolize these compounds wherever it runs into them.
And they're supposedly evenly distributed because your blood is...
I'm not going to say evenly distributed.
Well,
You'd have a highest concentration in your liver,
oh, yeah.
because that's where you're excreting them.
But outside of that,
But you might also have some differential concentrations in the stomach.
in the stomach itself, or...
Yeah, some of these
in the blood vessels?
CYP enzymes are present in the stomach.
How do they get in there?
You have secretory cells in the stomach as well. Stomach makes a bunch of stuff. It's not all digestive. It makes...
And what about, they get into the brain readily?
Now, you do have enzymes in the brain that break down neurotransmitters
Mm-hmm.
and may break down a drug, but those are not liver enzymes
But
typically.
do the liver enzymes get up there? Are they small enough to go through the blood-brain barrier? You would think so. Or
No, I wouldn't think so, actually.
You wouldn't think so?
I would think they're peripheral, but
That's a good question, isn't it?
it's a very good question. I'm not going to make up an answer when I don't know.
And I'll take it on myself to find that out.
I'm betting they're just too big and complex. Those are, and these enzymes are probably going to be molecular pretty complex. And I don't know if they're going to be fat soluble either, so.
They don't come in right and left-handed varieties. They're all,
No, I'm not going to
Just
say,
the same.
I don't know the biochemistry well enough to say.
they're all androgynous.
CYPs.
Or so,
Ambidextrous.
which is more dangerous for cirrhosis of the liver? Benzos, barbiturates, alcohol?
The fact that, so there's this mention about elderly people not metabolizing benzos very well, but that doesn't, I don't think that's predictive of cirrhosis. That's predictive of them falling down.
Falling down.
If you give benzos to senior populations, a common outcome is that they don't metabolize them fast enough. They get supercorked and benzos fall down, get hurt, and die.
Yeah, if you're over 65 and you break anything below your belly button, you know, it's over.
And the rate of trip and fall with senior citizens and benzos is high, really high, because they just don't get rid of them.
when I get that age, you know the little things when you're learning to walk, that has little wheels on it, you attach, I'm gonna attach one of the, no walkers, I'm gonna have, so if I fall, I'm like, it's all over.
If you want, briefly go over, what, barbiturates and benzos. Benzos are safer, it has to do with the tolerance, metabolic and their pharmacodynamic.
Yeah, so they have different therapeutic margins, which is just another way of saying there's a difference in safety, but that doesn't explain why. There it is. So the therapeutic index, which is actually the LD50 colon ED50, 7.8 to 1, 20,000 to 1. Okay, so this is clearly, there's a much wider margin of safety here. Now speculate for a moment, you probably know why that is. When you're taking this, what is it doing? Mechanism of action of the barbiturates. It opens the GABA receptor on its own, independently. Exactly. So if I load you up on phenobarb, it's as if I loaded you up on GABA. If I load you up on benzos, the depressant effect stops at the point that you are
GABA receptor.
you're using all your GABA. So it's because, I mean, GABA is logically somewhat self-limited. You know, we're not gonna
GABA kill ourselves.
yeah, exactly. We're not gonna make up GABA to kill ourselves. Therefore, since benzos are GABA dependent, it's harder to die from benzos. So what happens at 20,000 is you have so much benzo that you are literally, I'm guessing, you are literally using every molecule of GABA you can find. And at that point,
So in terms of lethality, I should focus more on, like, the dependence of GABA and less on, because in this one, slide 4, on barbiturate PowerPoint, it talks about metabolic tolerance and pharmacodynamic tolerance. The bottom, that's kind of throws me off a little bit.
okay, so that's different than barbiturates versus benzos. Okay, this is why are barbiturates so dangerous? So here's what we know, so barbiturates exert one action, they act like GABA at the GABA receptor, and they do it in multiple sites. And depending on where that action's occurring, will produce different effects. So let's imagine that the barbiturates go into your amygdala, the little emotion-creating brain center, and suppresses activity in the amygdala. What's going to happen? You're going to chill. That's the anxiolytic effect of barbiturates. The reason they were once used to treat anxiety is because they basically suppress the amygdala, which is your seat of feeling free. Okay. On the other hand, and so that's the anxiolytic side, we tend to develop tolerance there relatively quickly. So if I want either the drug, the pleasurable, sedative, chill, or the anxiolytic effects, over time, what am I going to have to do with barbiturates? Take more and more. However, in the hindbrain, brainstem, when the barbiturates are binding, doing the same action, but they're in places like the respiratory center. Now, we do not tend to develop tolerances rapidly in those brainstem structures. So as I'm taking more and more and more for the anxiolytic effects because of tolerance in the mid and upper brain, I'm pushing my lower brain closer and closer and closer to its shutdown. That's why barbiturates are dangerous. That's what this is about.
So it's more to deal with areas of the brain
Yep.
that develop tolerance.
Yep. And the fact that different receptor sites in the brain can develop pharmacodynamic tolerance at different rates. Make sense?
Yeah.
First of all, metabolic tolerance versus, there's three kinds of tolerances.
Yep.
What are they?
Okay, metabolic, pharmacodynamic, and behavioral.
And what should we know about those three?
Okay, metabolic means you develop generally more CYP enzymes, you can destroy the drug faster. So that's going to push your plasma level down sooner. So what would you predict? If I have less of my plasma, that's going to predict
Less effect.
because, say it again?
Less to bind on receptors.
Exactly. According to occupancy theory, if I got less in my blood, I'm going to occupy fewer receptors, therefore I get less of an effect. Perfect. But that has nothing to do with the receptors changing in any way, shape, or form.
Okay. Is that the only type of metabolic tolerance that you make more enzymes, or do receptors get changed in a
The
different?
receptors is pharmacodynamic.
Okay.
The minute you pull the receptors into the game, you're now talking pharmacodynamic.
Okay.
And yes, receptors change. They can either develop less affinity, so a molecule can just float by, or they have lower probability of opening when a molecule binds on,
Okay.
or over a very, very long-term process, you can actually change the structure of the receptors so they just don't bind at all, or you stop making them. So there are lots of ways you can become pharmacodynamic tolerant.
Okay.
Then finally, behaviorally tolerant. In every way we can measure neurotransmitter levels, cellular activity, metabolic, it's clear that the drug is acting on your receptors, but you don't act as if you've been affected.
Oh, really? You've learned to adapt to whatever it's doing.
Behaviorally tolerant.
That doesn't really necessarily happen with benzodiazepines and barbiturates, do they? Because, like for anxiety, just for an example, you wouldn't have the station effect or it's an anxiolytic effect, and then act like you're anxious. Unless you're
I didn't show any data of showing behavioral tolerance to the GABAergic compounds. Well, excuse me, the benzos and the barbiturates. So I'm not going to say yes or no. Clearly, we do have behavioral tolerance to alcohol.
Yeah.
So lots of people who claim, I can drink all night and not get drunk, what they're showing is behavioral tolerance. Behavioral tolerance tends to have a pretty narrow margin. So let's go back to the treadmill study. Okay, 60 minutes, those rats had adapted to the high levels of ethanol in their brain. They could stay on the treadmill. What do you think would have happened if I put them on a high wire? Because they weren't behaviorally tolerant to that task. Thus, the issue with people who abuse alcohol and are convinced they're not drunk for specific tasks which they've learned to execute with alcohol on board. If the task changes, we know what's going to happen. And that's why field sobriety tests, they're going to keep running you through tests if they have reason to suspect. Because you're going to eventually fail one of them if you're inebriated. Well, if you practice them all, oh gosh.
On the videos, the cops and the shows where you see them going through the things, but they ask them to do one test, but they memorized a different test, and they're doing it pretty good. He's like,
You're talking the guy that can sing and do everything, and he can do the alphabet backwards and all that stuff?
I don't know if I've seen that.
Oh, it's the funniest thing ever. It's this guy, and she takes him through all the motor behavior stuff, touch your nose, toe to heel, all that stuff, and he rocks. Then she takes him through a bunch of cognitive stuff, and he rocks. And then she gets him to dance, and he's completely cool. And he says, in fact, we should change this dance. And he starts suggesting moves. And she said something to him like, are you just a great dancer? And he goes, no, I'm just drunk. Oh! It's hilarious.
Oh,
You gotta go see it.
Inhibition.
It's hilarious. It's the funniest thing. Because he clearly had been practicing the field sobriety tests. Okay, never mind.
It's kind of for personal question. If you were I'm not talking about its set of effects which it has on you. So it depresses the sympathetic nervous system.
In the periphery.
Yes. So if I'm trying to do a sport activity, would that have a great effect? I know it would have like a small effect at least, but would it have a huge effect?
It's a good question.
We should try it.
So like say I was going to physical therapy and I was anxious about some other kind of deal or physical therapy itself, could I get with that and then still perform tasks at a relatively normal level?
I'll have to look and see what the magnitude of that effect is.
Yes.
I think it's an interesting and relevant second effect in terms of its anxiolytic properties. It's not the primary reason it's anxiolytic, that's because of the serotonergic effects. But let me see if I can find something about the magnitude of that effect. It's a great question. But I mean, I would guess, I don't know, just as there are sports that like shooting sports, they don't test for steroids, they don't test for HGH, they test for beta blockers. And my bet is they test for steroids.
And you're not allowed to take them if...
It's performance enhancing.
Well, yeah.
Pro golf tests for beta blockers because it really enhances putting.
So you can't be taking a beta blocker for anything if you're a golfer.
No, you can. You have to have doctors. I mean,
Yeah, but you get high blood pressure.
yeah, you
Everybody's
could.
got that.
Yeah, you could. And you can also take performance-enhancing drugs for the right medical reason as a swimmer, runner, weightlifter. And it's amazing how many of them contract those diseases.
You said in class not to focus as much on the non-barbiturate sedatives.
Like I said, the GABAergic unit.
GABA. What does it look like when when we have enough GABA in our system and we're not taking any drugs and don't need to take any drugs? Can you describe what it looks like?
Normal GABA levels?
Yeah.
You're just calm.
Calm?
Calm.
So like you're sitting in class and you're just not jittery here.
But you could get, if the fire alarm went off, you could easily rise to the occasion.
Because your glutamate levels are going to take off. In the periphery, you're going to have a sympathetic response.
So it sounds like GABA is a parasympathetic.
It's central. The parasympathetic is peripheral.
It won't have any effect, like, to increase glutamate, I guess, that in turn would affect peripheral, but...
I don't think the parasympathetic is peripheral though.
Yeah. It's part of the autonomic nervous system,
I
which is
know.
peripheral.
But rest and digest.
Right?
I think cognitively I'm resting and digesting. And if I need to get up, I can because I can.
Correct. But that's through something called the HPA axis. So the hypothalamus signals the pituitary, which then signals the adrenal, and the adrenal either activates or inhibits the sympathetic nervous system.
So by way of the
Yeah.
endocrine system that gets out there.
So guess what tells the H in the HPA up or down? Glutamate and GABA.
Is the HPA different from the HTP?
Thyroid?
Yeah, I've seen that axis, and I've seen that one that you're talking about, and I've seen the
HTP, hypothalamus, I don't.
pituitary, thyroid, it's thyroid, pituitary, and
That's
like
backwards.
I know, but
And HPT, I can imagine, but I don't know what it would be about except for hunger.
what is the H in your scenario?
Hypothalamus.
And it's HT, what is yours,
HPA. That is the standard stress, central control of your stress response, the HPA axis.
That's probably all there is. There's probably no HTP or HTP or PT. Okay.
Yeah. So central structure, the brain, can modulate the peripheral system, the autonomic, through the HPA by way of the adrenals.
Well, it can and does, right?
Yes.
So good GABA. What if someone had bad GABA levels and they're not taking any drugs in it? What would you expect them to be anxious?
You mean they don't have enough?
Yeah.
Yeah, but I don't know that the anxiety disorder is necessarily associated with deficiency. Well, that's not true. There is the GABA deficient theory of seizures.
Okay.
That's in there. Now that's sort of tangential, but it is in there. That one of the ways we see GABA's importance, aside from the anxiety disorders, is GABA kind of keeps a brake on the central nervous system and prevents seizures.
Right.
You find that real clearly.
No one ever has too much GABA, do they? Or GABA doesn't get metabolized fast enough internally. That's not something that happens typically with humans. No? Too much GABA?
I see more about the deficits in GABA than the
Okay.
excesses. So this is toward the end of the barbiturate section, the GABA deficit theory of epilepsy, which is why the standard treatment for epilepsy for a long time was phenobarbital, because it's substituted for the absent GABA. Now, we have replaced that now, and so what we're doing is, instead of enhancing the inhibitor, what lamictal is doing is shutting down the excitatory side. So the way we used to treat epilepsy is by enhancing an inhibitory process, GABA. We've shifted over to using lamictal, which shuts down the excitatory process. Those are different.
My last question, I gotta go. So normally, what occupies the receptor site that benzos go to is beta carbolines, right? That make you more anxious. That's their job. So a molecule, because I just confused me, because I figured that receptors like only have certain roles, you know what I'm saying? So like a receptor that works to make you more anxious could be occupied by a drug and then make you less anxious. That throws me off.
But, you know, remember, think about the origin of these two molecules. Where did beta carbolines come from? Evolution. Where did benzodiazepines come from? Exactly. So they just kept tinkering with the molecular structure in the lab until it did what they wanted. And the reason it did what they wanted is it happened to fit the receptor site for the beta carbolines. But then when it got there, it didn't do what the beta carbolines did. So when the binding occurred, instead of allosterically modulating GABA down, it allosterically modulated GABA up.
Okay. So a receptor has that ability to work either way.
Absolutely.
That's crazy. All right.
I mean, for example, later, you know, we'll talk about acetylcholine, I think. Acetylcholine receptor sites on the postsynaptic membrane are happily occupied by a lot of drugs that just happen to have a molecular fit.
That can elevate or
They can either be agonistic or antagonistic. Yeah.
That's weird.
Sweet.
And sometimes the fit is imperfect. So you got affinity and then you got potency. So a molecule of beta carboline may have a probability of shutting down GABA that's very, very, very high. A molecule of benzodiazepines may have a probability of enhancing GABA that's so-so. So the beta-carbolines would be more potent in that case. So lots of times when you tweak drugs, so you go from the 1995 version of Adderall to a new version, all that you've done is you tweak the molecular structure to make it more potent.
You might
Change
change
receptors.
You could change the polarity from the left-handed to the right-handed.
Any of a number of little things. Okay, and you did get that, I thought that metabolic destruction of GABA and how it would play out in the 3 drug classes was a cool thing.
Yeah, got it. Thank you.
I want to make sure you got it.
How it played out.
Yeah, remember at the end of class on Wednesday, we ended up with that thing about what would happen if you metabolically destroyed GABA.
Yeah.
What would it then do to the function of these 3 drugs we've talked about?
Yeah. I was glad my recorder was working.
Ethanol was the only one that worked on GABA and right?
So I'm going to have to come up with an analogy for that, with the whole receptor thing. A key in a door, that's fine, but then this is a key that can lock the door or unlock the door and actually change the size of the doorway at the same time. And then there's an endogenous thing.
Well,
So
not exactly.
that's a terrible analogy. I need to come up with a better one. And I will.
Instead of thinking about changing the size of the doorway, because it kind of the doorway's open, the doorway's not open. That's
Right.
really kind of binary.
Mhm.
It's the probability that the key's going to open the door.
Right, but once it does,
It's open.
right, but it's a terrible analogy, because it could inhibit or it could increase or decrease the activity of.
Okay, so I'm sorry, go ahead.
Oh, I was asking one key, I missed the first part of this.
Huh?
Are we talking about beta-carotene?
We're talking about what he was talking about. The receptors these drugs can act on endogenous receptor sites in a positive or negative way, and then in an affinity way, and I was saying, I think a person come up with something.
So I often use the key and lock metaphor as well, but you have to sort of broaden it to think about this. There are keys in the world that are drawn almost inexorably into the lock. There are keys that would only go into the lock under great duress. Okay, that what you're describing there is affinity.
Mm-hmm.
That's one dimension. Then, once the key is in the lock, it fits and effortlessly unlocks and opens the door. That's potency. Or, it doesn't really fit that well, and if you jiggle it and mess with it, it will maybe eventually unlock the door. That's low potency. Then there's some keys that while they're in the lock, they're never going to unlock the door. But while they're in there, nobody else can get in. That would be an antagonistic drug. They're really important drugs.
Name one.
Buspirone.
Yeah. So,
Yep. It is antagonistic on the postsynaptic serotonin binding site. It fits right in the lock, but does not open the serotonin channel.
when you say antagonistic or agonistic, is the context what that site was meant to be?
Yeah.
And what that particular site was meant to be?
Yeah, and I stumble over it because it gets a little tricky when you start taking all the different receptor types into account.
Mhm.
Because, so for example, on the autoreceptor, that thing that's on the presynaptic side,
Mhm.
if I open the channel on the autoreceptor, so that's agonistic at the receptor, right?
Mhm.
It's doing what it should do. But then what does it do to neuron function?
It's agonistic?
It shuts it down.
Why does it shut it down?
Because the autoreceptor is the
Oh, it's the
brakes.
negative feedback loop.
Right.
It's too much, yeah.
So
Right.
that's why I kept kind of switching between inhibitory, excitatory, agonistic, antagonistic.
But you have to just consider the context. Are you at the receptor site?
And if you're not sure what you word to use, describe what's happening.
Yeah, at the cleft.
Does the cell fire more often or not?
1970s where they shrunk a little submarine
Fantastic voyage.
into the person's veins. Yeah, we need to do that. I want to see, I'm going to have to probably draw a neuron that's as big as it needs to be able to draw the individual receptors on the nose and be able to contextualize all of this, because it gets so fuzzy. It's like, we're always in close-up. We're never in medium shot. And the thing looks like a tooth, which I've not been able to find. I don't know what slide that's on. It's a
The
neuron.
benzoreceptor,
It just looks like a tooth.
excuse me, GABA receptor.
Yeah. We're looking at that, and I'm thinking, is there one of those on the neuron, or is there a bunch of those? There's a bunch of
I
those.
think
I don't have what slide is that in which?
19 in the benzos,
Okay.
and it's also, I put it up twice. Oop, that's ethanol, sorry. No, it's not, it's part. Why is that coming up under part? There we go. It's 19 in the barbiturates. No, it's not. Yeah, it is. 19 in the barbiturates and 9 in the benzos. I'm sorry. If you Google GABA receptor, you'll get tons of drawings.
Oh, I know.
And the idea is they're called columns, they're called units, and they're basically structural pieces on which these different receptor sites reside. They're not kind of just scattered around on one structure. They're literally structurally separated. So where the ethanol receptor lives is on a different unit or column or piece than the benzoreceptor.
But all of those columns mixed up? Okay. So it's... Yeah, don't have one. Okay, it'd be like if you had a field and you're a farmer and you threw out a bunch of corn seeds and a bunch of pea seeds and a bunch of cabbage seeds, and they grew. On the individual plants, there's unique things, but they're separate, but they contain what they contain that's specific to that particular vegetable.
Hold on, let me get back with
Did you
you.
follow that?
Okay, here's a good one. So see how, there's your tooth. Can you see the tooth, as you call it? And you see how it's got these, so you got beta receptors, alpha receptor, gamma receptor, and GABA fits on beta. The volatile anesthetics, which we're not talking about, that's ether and other things, fit on the alpha. Ethanol fits on the alpha.
But that's how they look. They're like,
No, it's a hunk of protein. So
yeah, but
it's,
they're like columns like that?
they are units.
They
They're
go
distinct units.
Inside and out. Okay, I didn't realize
And
that. That's cool.
they do span the cell membrane.
Mhm.
So they span the neuronal cell membrane.
And they're clumped together.
Yeah.
They don't,
And in the center is the ionophore, the channel through which chloride will pass.
and any one of those may or may not cause that to open.
Well, sort of. Ethanol can open it, barbiturates can open it, benzodiazepines help GABA open it.
Now, that makes more sense. It helps it open it.
Mhm.
And so you wouldn't have one of those GABA little, let's call those bones, those are bones to me. You wouldn't have them separate, 6 inches to the right of that. They're a team
Yes.
on that particular neuron.
Yes. And there are thousands of those on any given neuron.
So there's a 1-to-1 ratio for the different types of receptors on any one.
I'm not sure I would say that. I don't know
Well, then
that.
how would-
That implies there's only one ethanol binding site on this gamma, on this alpha unit. There could be multiple binding sites.
No, I mean the units themselves, there's a 1-to-1 ratio. That bone thing, there's 5 of them, so there's one in each of those. Actually, there's 2
Yeah,
betas.
that's fine.
2 betas,
Yeah.
2 alphas, okay, you're
And
right.
it's actually alpha 1, 2 through 5, beta 1 through 4, gamma, yeah. And so you'll have, because remember, for example, the GABA receptor in the brain have benzo binding sites. The GABA receptors everywhere else in your body don't.
show that in that, where would that be?
Benzo site. It's on the alpha
Oh, okay.
and gamma, I think. It's probably why it's in the border here. So you would only have this type of GABA receptor in the brain. Elsewhere in your body, it wouldn't have this binding site.
It wouldn't have that side, or it wouldn't have the alpha?
It wouldn't have, that's what I'm saying. This is saying there are 2 alphas, 2 betas, and gamma, but in fact, there's like alpha 1 through 5, beta 1 through 5, gamma 1 through some. There are different forms of those. That they may all have 2 alphas, 2 betas, and gamma, but it could be alpha 2, alpha 3, beta 1, beta whatever.
And where's the benzo is always on the alpha?
It's on the, yeah, I think it's on the alpha in the brain.
Unless you're mutated.
Because they're just centralized in the brain.
Benzo is centrally active. Doesn't do much here peripheral.
Should take mindlessness.